to work or not? What are the motivation factors that will support users to use this Afya-Tek system? So that was the end of 2022, and we got a lot of learnings, and we have some of the publication that is going around, so you can look at it and share and learn some of the lessons learned. So the current phase, which is now 2023, 2025, we are incorporating Afya-Tek into the National Unified Community System together with the autonomous to ensure that there is a complete care pathway all the way from the community to the health facility. What we wish to see is that once a patient actually arrives at the health facility, the doctor is able to assess what this patient got at the community level. Was he or she screened at any danger symptoms? Was she given any kind of medication at the early? And this will be very important, particularly in terms of assisting the healthcare provider to provide better treatment to this patient. Of course, the next phase that we envision 2026 going forward after the program ends is that the government takes lead in terms of scaling and sustaining this program elsewhere. But again, Afya-Tek is a great platform that can incorporate other disease conditions, NCD, TB, malaria, and actually, I was happy to hear from Losh. I don't know is Losh here? Yeah, they just finished their presentation. They said that they have actually funding. You can apply funding to test initiative like TB in these premises. Next slide, please. Yeah, so these are some of the program achievements. So, first of all, we've been able to demonstrate a digital system. As I said, it was a bit complex, but then, of course, the partnership, the government of Tanzania, the Ministry of Health, Farmers Council, and POLA. So we are able to showcase that the public-private partnership at community level can work. And we have seen, of course, a number of referrals that are coming from the adults to health facilities. Again, we have established the foundation for sustained and national scale. And as I said, currently we are linking Afya-Tek with the unified community system of the Ministry of Health and Ecotomy. But again, we are working close, as I said, the Farmers Council and TBA, and I think this is the avenue for the Farmers Council as well to understand what is happening at the adult. Because currently there's no system that actually shows what is happening at the adults. So it's important for them as well to regulate and provide some kind of guidance towards the adults. We have prepared the government for ownership of the Afya-Tek program, so we're doing a lot of capacity building session with the government's ICT team of the Ministry of Health and POLA for them to better understand the Afya-Tek system as we go towards the ownership. But again, we have built the various dashboards of the program, and currently the listed health teams in Kiba, the CHMTs and their own dashboard, they can monitor a number of indicators, what is going on in the community. Even the basic pharmacist himself is able to understand what is happening at the adult, for example, and intervene when necessary. Again, we have created a strong platform for learning. So as part of implementing the program, we learned that, of course, the adolescents mostly prefer accessing treatment services at adults because of the privacy and confidentiality. So these are the key learnings that we need to bring forward in terms of implementation in future. But again, as I said earlier, these are some of the potential programs that can, platform that can incorporate a number of disease conditions, not only maternal, child, and adolescent care. So if you go back, and I want to show you some of the, back again, yes. So far, we have witnessed a number of referrals that are coming from the community health workers, the health facility. So we have more than 39,000 referrals from the community health workers at the health facilities. And with regard to the linkages from the community health worker to the adult, so we don't call these referrals because they're not supposed to be part of the adult community health worker, so we call them linkages. And these linkages are only specific for selected illnesses or symptoms. For example, headache or cough or skin rashes is when community health workers are allowed to link this client to nearby adult. And we had a very great discussion with the Ministry of Health because actually all clients are supposed now to go back straight to the health facilities. So we have more than 24,000 linkages from community health workers to the drug outlets for minor illnesses. But again, interesting, we have more than 4,000 referrals from the adults to the health facilities. So we can see that, as I said before, that they are leaving no one behind. According to the health sector strategic plan theme that we have now, that it's important to connect both the public and the private sector to improve quality of services in primary health care. Thank you so much.
introduction before it's a ticketed system. Afya-Tek. Angel is not only the director and the head of the Afya-Tek, but she has also extensive experience in health system and community research, focusing on access and quality in particular. She has worked as a research team leader in a number of projects, in particular by the Health Institute, and most important, she has a PhD in epidemiology from the University of Basel and has published over 50 papers, more than 50 papers, mainly in peer-reviewed journals, which really counts. So that is a huge achievement. So thanks, Angel, and please take your seat. May I now call on Fatma Mahmoud, also from Apotheker. Fatma serves in the Apotheker NGO as an Innovation Strategies and Partnership Officer. She works around really connecting with various stakeholders, forging cross-sector partnerships, and designing evidence-based strategies. She's responsible also for managing the digital components of the programs together with our partner T3. Before joining Apotheker, Fatma worked as a CEO of various companies. One of them is Blending Tanzania Limited, and she has a degree in Business Information Systems from the University of Greenwich. The next speaker I would like to introduce, very well known to all of you, Dr. Tui Logwe, graduated as an MD from Dar es Salaam and got an MPH from the University of Rome. He has worked a lot on direct health facility financing. Then I think Dr. Tui is Baba THS, because that is really where he did a lot of work. But his best time, confidentially told me, I will express it, his best time, he always mentioned, is having been a DMO where you really learn the nitty-gritty work of the medical health systems in Tanzania. After that, he became an RMO in Shinyanga, he became Director of Health, Social Welfare and Vision Services in PO Routes, and then he moved to recently to MOH as the Director of Preventive Services. He has conducted a lot of implementation research studies himself, and he guided those studies, and has also more than 70 published publications in a peer-reviewed journal, and is the editor of an important book, if you want to read that, is The History of Primary Healthcare in Tanzania, Senior System Plans. It just came out at the end of last year. Thank you. Mark is the Principal Information Application Officer at the President of Europe, and the President of Government. Extensive experience in government institutions. Previously, he was working in the Parliament of Tanzania and currently in Europe. And in his current role, he is the team lead for several critical projects, including the development of the Treasury Registry Plan Web, and several public institutions he worked with. He leads the development of the Desesha portal. He also oversees, and that is very important, the centralized GeoT Thomas, the GeoThomas project, in trying to put all the data together in one single database covering all our 2,700 facilities. Thank you. Then Eden, he represents D3, our partner in this project, the Afya-Tek. He is the senior technical advisor of D3. Has over 10 years of experience in daily digital and data roles with various organizations. He worked with TAIOA, he worked with USAID, and he worked with PAS, and now in D3. He holds multiple degrees and certifications in IT, in finance, and project management, etc. He did very well. And last but not least, coming back to my favorite job in Tanzania, is the DMO. The DMO of Kibaha our district, the medical doctor, both the clinical aspects, teaching, research aspects, having a bachelor's in medicine, ACMC, and a master of monitoring and innovation at the university. He said that he really liked, and I like that myself very much, he likes to mentor his students and the healthcare workers wherever he meets them in the districts. It is an extremely important function of the DO. He does that at all levels. He has been involved in implementing community health and MCA's currently West Child Healthcare activities. So let me now go back to our first question. So the first question is in fact to Dr. Tu about the role of Afya-Tek within the primary health sector. As you know, Dr. Tu, primary healthcare is the key pillar of Tanzania healthcare system, and you are very much an essential person in that. Now, how do you think that private pharmacies and drug outlets, the emphasis on drug outlets, would fit into that strategy of primary healthcare? Before and during the introduction, I talked about that self-care parallel systems to others. Now we have seen how Afya-Tek can do something about quality improvement. So now for the industry, this would be key to learn those lessons and integrate, expand it to the rest of the country. How can we have those lessons learned and to integrate them in the national and local healthcare frameworks in order to improve access, coordination, and in particular quality of service delivery at the community level? Not so easy question. I'm sure you can address it very well.
Thank you very much, Eric. I must say that primary health care is an approach, and systems, these are means which will take us to the university's coverage. I'm a strong believer of science and innovations, and I was privileged also to be part of the people who supported the implementation of Afya-Tek. But in the course of implementation, what we were able to do was to conduct an implementation research that allowed us to gather the evidences that will inform us whether this was a suitable initiative or wasn't a suitable initiative. So we were able to work together with a team, and from the research findings, then we were confident enough to say that we can be able to take this project going forward. And the most important when it comes to the Afya-Tek was the tripartite nature, where you have three players working for the common goal, having the private drug outlets, having the CHWs, and having the primary health care as the center of this initiative. And, but at the same time, the most important thing which we were considering is whether this tripartite arrangement would not lead us to having a crisis. And the notable crisis which I'm talking about, the antimicrobial resistance. That has been now a huge challenge at the national, regional, and global level. So we wanted to make sure that whatever we're introducing, it shouldn't lead us to a place where we want to be able to run away. And then antimicrobial resistance was one of the things which we had considered. So looking into the Angel's presentation, the referral pathways for the Afya-Tek, having the CHWs, and luckily now we have just launched the new integrated coordinated community healthcare workers program, which we launched in March this year, and the package they have. Then we said this is a project which is scalable. This is something which we as a government, we have to take as a key input to curriculum development for the new CHWs, which the training started about 2 days ago. And one of the things, or one of the assignments, will be for them to actually dispense some of the medicines, including the antimalarials, the first dose, upon the positive test for the malaria. Then the issue of consultation, the issue of counseling, which is also part of the package which we have, and those 7 modules which we have. So those were the factors which led the government to decide that, okay, this is something which we'll have to consider taking it and rolling it out. But how are we going to do it? Not taking it as a standalone thing. We have to integrate to the existing system, the community healthcare system. So this is all not only to the Afya-Tek, but also we have the health entrepreneurs. I think Nicole might be here and others. So we gathered evidences from different stakeholders, from the private space, so that we can have impetus to create a model that will be a unique one to address a couple of challenges which people experience at the community level. So Afya-Tek has been that partner who has been engaging the government from the inception to date.
Thank you very much. That is really very good news, and it leads straight, in fact, to my second question to Angel, because if quality is your sales item, that is why people get better and why you can avoid resistance. How can you get a little bit more in detail, Angel? How do you install that feeling for quality in the day-to-day activities of an adult assistant, nursing assistant?
Yeah, thank you, Eric. Of course, quality is an issue that we need to focus on. And again, for the adults, we did not start from scratch because we are working with adults who actually received training all the way from TFPA back then and the Farmers Council. So adults, they received a number of training, including training on integrated management of childhood illnesses, but also other training on maternal and adolescent health. So part of this training for them, for example, the MCI, adults have been trained on assessing danger symptoms and provision of referral to health facilities. Even by then, the Farmers Council provided them with some kind of referral books where they should screen parents and refer them to health facilities. But again, this was a challenge because they were using a paper-based system. And currently, this digital system that allows them even to better provide services. So what we did in terms of the adults was to simplify their dispensing practices through a digital application to allow them now to better screen and provide referral to health facilities. And of course, the other thing that we use to improve the quality, of course, as I said earlier, is to develop dashboards together with the CHMTs in Kiba and the Farmers Council. So we developed adult dashboards that allows the district pharmacists to monitor a number of indicators, but also allows him to actually assess the low performance within the adult and conduct some kind of supervision. Again, we've been supporting the district teams in terms of conducting inspection of the adults so that we are monitoring the quality of medicine that adults are supposed to receive, or are supposed to dispense at the outlets. Again, as we all know that adults, apart from provision of these services, they are also interested in making profits. So we're also coming up with an intervention to, of course, support their business too, so that they're able to assess profit, sales, and expenditure as a way of motivating them to also provide better services. And we've been working closely with the Farmers Council on this. Again, using the dashboard, identify those who are good performers and provide them with the certificate of recognition from the Farmers Council to allow them to motivate them to actually improve whatever they're doing in terms of dispensing medicine, but also provision of referrals to the health facilities. So all these interventions, we've actually seen a number of increase in terms of success indicators. For example, when you started the program, we had zero dispensing of ORS in zinc among the adults. And because most of them prefer to provide antibiotic for children who are mild diarrhea. But currently we see an increase actually from 0 to 35% of children with diarrhea who are provided with ORS and zinc as a complete package for that. Thank you.
Thank you very much. It's a very good example. Now, one of those key elements is, of course, as Angel mentioned, is the digitalization, the reporting and referral system. So let me go to which has played really a role in reporting and ensuring this continuity of services to information gathered by the others, by Afya-Tek's projects, are integrated within the existing unified community system and the geotoys. Because that is where the matter comes together. Can you explain that a bit more to us? Thank you.
Thank you very much, Mr. Eric. First and foremost, this is a national call. When we speak about interoperability and integration, from Her Excellency Dr. Samia Suluhu Hassan, the President of the United Republic of Tanzania. Second, with dichotomies with PRH, this is within our solution hub. Meaning that we really needed to get the referrals done for the continuum care from the community up to the facility, and then up to the RRH, and then to the data, to aggregate data with the national data analytics like THS2 and stuff. But secondly, our objectives are clear when speaking about the integration between the community systems. In this case, talking about adults. Our first objective is to have seamless referrals. We need to streamline the referral process so that the systems could interact and they have to communicate to the higher level facility, for example, from the community to the dispensary, and from the dispensary to the health center, and making it very lenient, and so that we could accumulate more data and help people to make good decisions. But also another objective is to ensure that we have a very proper and improved coordination of care. When you bring referrals from the community, carrying the screening of the client, but also having the medications and the prescription, and then the whole information will be accessed by the health provider at the facility. It will ease it will improve, and get a better treatment plan. So see that even the decision that will be made will be based on the accurate data collected from the adults, collected from the community. And the last thing is to really make sure that the prescriptions and the medications that we receive will have, a continuum of care. Right now, we have a plan, and we have now started planning. We are assessing. We have to establish the data elements that we need to exchange between the two systems to make sure that we really have this, we really achieve our goal, which is to have the continuum care, and make sure that we go within our words that we need to have a single record, a single patient with a single record. So whenever you go from the community to a certain facility, then you will be able to access whatever you got from it. So by doing this, we reduce some medicine errors, but also I think it will be easy to track the prescriptions and the adherence to medicine by our clients. Thank you very much.
Thank you very much. That is important. Innovations in tracking innovations in the use of data. That you are doing that, you have done, and you're still work in progress. Let's go back to Fatma from Afya-Tek. How do you see things that these innovations, these necessary innovations, which are being put in place by this project, how do those innovations ensure that they are aligned as much as possible in that way with the community systems we have, with the state systems we have at the district level, at the regional level, and at the national level? That alignment needs to be there. Can you elaborate a little bit more?
Thank you, Eric. Afya-Tek system hasn't changed much in the existing government systems that have been in place, but rather Afya-Tek has improved the existing systems by engaging the government officials from the regional level, central level, and national level in co-designing the system. Afya-Tek has brought a human-centered approach in designing the system. From when we were designing the program and the system, it was people-centered. We put the people's needs at the center of everything that we do. From the community level, we have managed to engage community health workers, the society in updating the system, bringing ownership of the whole program. From the national level, we have managed to work seamlessly with our partners. We work very well with Pharmacy Council and the Office of the President, PRH, but together with the Ministry of Health from the very beginning, making sure that the data flow from the community has been used at the national level for decision making, but also at the regional levels. It's been very useful for them because right now it's conducting the projects of regions that are done in Kibaha. They're usually conducted by the regional teams and the central team. But also at the national level, it has enhanced the uptake of the system. As we all know, we've only been implementing for 5 years, but we've managed to scale the system and integrate within the unified community system. That speaks of the One Press partnerships that we have with the government, and I think it has spoken for itself with the wonderful partnerships that we have at the level of the government and the regional levels.
Thank you very much. Now, that brings me to the point that all these innovations, this triangulation, that all what you've done to QI in your project, in the end is under the auspices of the DMO, because the DMO is in your control. So let's go to the DMO, let's go to Wilford and ask him, what is your experience as the DMO there in Kibaha, where this project takes place, and what is your experience in ensuring that the program is owned by you, by the district, and by the community who are responsible? Can you elaborate a bit on that?
Asante sana Mr. Eric. Sikianza na experience ya kufanya kazi na Afya-Tek, hapo naweza nising'ate maneno nikasema kabisa wamefanya kitu kikubwa sana. Kwa nini kitu kikubwa sana? Kimeweza kunipa eneo la kufanya kazi na jamii moja kwa moja. Tunafanya kazi na community health workers moja kwa moja, wanaona wateja kule from the root. Kwa kama kuna changamoto kutokea kule chini tunaweza kuziona, na vile vile kupitia dashboard ambayo tuna access nayo tunaweza kuona zile referrals kwa baadhi ya magonjwa yako mengi sehemu gani, ambayo itatufanya twende moja kwa moja kwenye jamii husika. Kwa mfano, kwa nini referrals za magonjwa ya mlipuko yamekuwa mengi kwenye kitongoji fulani? itatufanya twende moja kwa moja kwenye jamii. Kwa hiyo ni mojawapo inatupa uwezo mpana wa kufanya kazi jamii moja kwa moja kwa kutumia community health workers. Na cha pili nikisema kwamba ownership ya mimi kama DMO au halmashauri kwa kufanya kazi na Afya-Tek, naweza kusema ownership ipo, kwa maana ya kwamba namba moja, tumeweza kuwa na team members 5 ambao wamekuwa trained na program zote za Afya-Tek, na sisi sasa hao team members tumewatrain hawa community health workers. Moja kwa moja inaonyesha kwamba umiliki ni wa kwetu kwa kuwatrain wale community health workers waweze kufanya kazi katika kazi ya jamii. Kitu cha pili, Afya-Tek wanafanya kazi kidijitali. Tunapata taarifa za kidijitali. Kwa kupitia platform hiyo tumeweza kuwezeshwa kumtrain ICT wetu mmoja ambaye atafanya follow up ya simu zote wanazotumia hawa community health workers. Kwa hiyo ya pili inatuonyesha kwamba wote tayari tuna ile ownership ya nini kinachoendelea. Na cha tatu ambacho ni kikubwa kabisa, kupitia dashboard yao tumeweza kutengenezewa dashboard ya CHMT members. Wanaweza kuona kwa kila mratibu, nikichukulia mfano mratibu mmoja labda wa mama na mtoto anaweza kuingia kwenye dashboard akaangalia kwenye hamlet fulani ambapo kuna community health worker fulani amepewa malengo ya kutembelea labda nyumba 100, lakini kama ameweza kutembelea nyumba 2 tayari inatoka kiashiria kwamba hapa taarifa zetu hazifiki vizuri kwa wale walengwa. Unajikuta hata yale malengo ya kutoa elimu kwa mama wajawazito namna gani ya kuweza kukamilisha safari yao vizuri kutoka akiwa mjamzito mpaka amejifungua na mwanae kwa miaka 5 hayawezi kufikia kwa kutowapa maelezo ya zile dalili za hatari. Kwa kupitia dashboard hiyo waratibu wetu wanaweza kuona kwamba sehemu fulani kuna changamoto. Kwa hivi vyote vinatuonyesha kwamba ile ndio ownership ya sisi wenyewe. Yes, kwamba hata kama mdau akija ku phase out tunaweza kuendeleza mradi, kwa maana kwamba kila kinachoenda kufanyika sisi tunakijua kwa 100%. Asante Mr.
Very clear that what you see, what I get from this presentation from the DMO, that there is this ownership and using of the dashboard is based on mutual trust. Trust from the government system with the project. And that trust to me is a very, very essential element. So thank you for bringing it up. It brings me then to the partner. The partner of the Afya-Tek and Apotheker is D3. And D3 is represented here by Eden, responsible for this digital development. Now, Eden, tell me, how do you in Afya-Tek ensure that your digital approaches are following the standards we as a country, as Tanzania has set, and following the standards set by WHO? How do you align and ensure that everything is made together? Can you elaborate a bit on that?
Yeah, thank you, Eric. I think without repeating what Mark and Fatma said, the real reason why we are here talking about scale and sustainability of the Afya-Tek program is because from the beginning it followed the standards. It applied the national standards at national level. I know we are talking about digital, but it all started with health. So from looking at the health sector strategy plan 4, that's where the Afya-Tek really was designed from, when it showed that youth and adolescents were more likely to visit the adult. So that itself showed the need for having ADO as part of the bigger health system. And so from there, moving in the digital space, we have digital health strategy as a national document which put all these standards, principles and guidelines on how to go about that. So we had applied the current digital strategy 2019, but also health enterprise architecture, Tanzania health enterprise architecture, where it puts on most of these principles. And I think to mention a few, One of them is the use of open source. It is put clearly in the health enterprise architecture as well as in the digital strategy, where open source, particularly in Afya-Tek, we use OpenSRP, which is the same platform that the unified operating system is using. And if it was not for that, I believe scaling of Afya-Tek. And the other thing is the use of local expertise. Italy and Apotheker, we developed the system using our own resources in terms of team. So we have in-country capacity to really be able to support this initiative. So I think these two are very key. I know there are a lot of other standards that have been mentioned in the health enterprise architecture, in other framework, global frameworks such as principles for digital development, where I think one of my favorite principle to me is design from existing, but understanding the existing ecosystem. So at that time when Afya-Tek was designed, the real reason why they chose OpenSRP, and I think we have a director from ICT here, is because of that, understanding the local, what is the local context from the processes and digital technologies and the platform. That's where really the idea of adopting OpenSRP came to life. So I think it was designed for scale from the initial inception, from the design, and that's why we are here today. Thank you.
Thank you. I'll say this ownership issue again. So that brings me now to you, because we'd like to hear from you what you want to clarify, but more importantly, what kind of comments or questions you have for us also to learn and for us to adapt and do better. Are there any questions or comments you would like to make? And there is a person in the back who will go around with the mic. I see one hand in the front. I see a second hand here.
Thank you. My name is Patrick Kumemo. I work for Maristops. So yeah, just to congratulate Afya-Tek. This is a very good initiative. So I have a couple of questions. One is, if other partners want to use the system, so you say you are at the moment you are using it in one of the regions or areas. If someone wants to use the same thing in another partner, are you able to give them access and the tools for them to do that? So that they will be working position and others deploy the same receptors. And then the other question is, at the moment, who owns the system? Is it the government or is it still the project program? Where is it hosted? So scale up plans. And then just a suggestion also. So I see you're working closely with adults, community health workers. I think we should also include pharmacists. I think it's important. I'm told at the moment now we have around 3,000 pharmacists in Tanzania. And so they are the higher quality versions of adults. And so I think it's a missed opportunity for not working with them as well. So they could be part of the process. Thank you.
Thank you very much for the excellent but it's not a question, rather is a concern. We all know the government is involving CHW and CHV into the government system, and therefore we are going to integrate the system to UCS, to the facility system, be it Promise or HMIS. Now the concern is the adult, this particular system is only in 2 districts in Tanzania. We have 184 local government authorities. So how are we? This is the consent to this room, including Minister of Health, my twin brother, is here, Yoraj, Director, our boss from WHO. Now, how are we going to roll out this particular system, this particular initiative to cover the whole of Tanzania? Taking into consideration is doing very well. And another thing is, how are we going to avoid to duplicate this particular initiative? You know, many silos in the government, in the community. So how are we going to avoid the duplication of this particular system, which is already doing very well
Okay, my name is Dr. Leon Igo. I'm coming from Private Scale Oyankuru Center, Tabora. I have some challenge, especially to Sister Angel, when you elaborate about the triangle of linkage from CHW to ADO and to health facilities. And the number never lie, because 39,000 people were referred from CHW to health facility, and the 24,000 were received linkage from CHW to ADO, and only 4.4 thousand were referred from ADO to its facility. To me, I get some contradiction. Like this ADO maybe is a normal practice, because the referral from ADO to health facility is very low. And when you go to, if there is a lot of practice to this ADOs, from providing medication which are not about them, to conduct deliveries, and to even process extraction to these ADOs. What precaution do we take as a nation? Because we can give them opportunity to receive referrals directly, and we provide them direct link of patient from CHW to ADO direct, and they do something which is completely wrong, and they cause a lot of challenges to this patient. And another question, it goes direct to Dr. Ntuli. We are training this CHW, and we train them to dispense some medication. What precaution also we take as a nation? Because they can start to act as doctors. I know some CHW who they are not themselves doctors in the society. What precaution do we take as a nation? Because we can create another doctors who are not registered, who they have no clear knowledge about dealing with patients, and create some difficulties in the system at all, while we are far away in improving health system in our nation. Thank you.
Thank you very much. And now one more question, and then we go to answers, and then we do one more round for the next set of questions. Last question now.
Thank you so much. My name is Amisi Msagama. I work with the Hawaii Society. I'm a trained pharmacist and work with advocates as well. I'm like 3 or 4 questions, but I will ask them quickly. So first is, Dr. Ntuli said when they were trying to implement Afya-Tek, the word was antimicrobial resistance, which is also of my area of interest. So what has been put in place initially to prevent the risk, and what do you see now from the initiative, from the initial stage? Second question is, we know adults, the problem for adults with the restricted antibiotic risk, and that's the big problem. So Afya-Tek being one of the platforms that's engaged with adults. So do you see it's a time now to revise the relevance of this and restricted antibiotic to adults? Either we keep them, or we train them, or we revise the list so that we improve the primary health care provision. And the third question is, I think it's close to the advice to engage pharmacists. So we know adults have the ability to upgrade to pharmacy, and training to adults, if I remember correctly, has been stopped. So we don't have new adult coming in, and also we allow for adults to upgrade to community pharmacy. So I think after that, I think it's also for me to give advice to move to engage pharmacists as well. And the fourth one is advice to also relate to the last speaker. So we have pharmacy dispensers, trainings with the background of medical. So I think it's also good to involve pharmacy dispensers to train them in the community and use them on community employees. It will be advantageous because they have trained as pharmacy dispensers, they have medical background, and now we can use them and we have a lot of them in the community. Thank you so much.
Thank you very much. That was a broad set of questions. So let me see in particular maybe questions to Angel and to Julie. Angel, can you start?
Thank you so much for very, very good questions. And I will start maybe with some, then my colleagues will jump into others. Yeah, the first question is if you want to use the system, because in case other partners want to use the system, yes, we're very much welcome that because currently, as I said, we are migrating the Afya-Tek into the national unified computer system, meaning that every partner can use it. So we can come up with other interventions, for example, for screening and provide referrals for even TB, HIV, and non-communicable diseases. So we are very much welcome and regarding the ownership, anyone will respond to that, but again, it's an open therapy that is owned by the government, so anyone can use it. Regarding the inclusion of the pharmacies into the Afya-Tek system, yes, this is what we wish to as well do next year, because of course, the area we're working with, there are also some pharmacies that we want to incorporate into the Afya-Tek program. So it's very, very important for the pharmacies as well to be part and parcel of the Afya-Tek program. And then I'll respond a bit about the questions on the referral. So if I may ask all of us, I think we've all visited the pharmacies, all the adults, right? Has anyone hasn't visited for any minor illness? Please raise your hand. Yeah, we've all been there. So adults are part and parcel of the Ministry of Health structure, because they are overseen by the Pharmacy Council and the Tanzania Medicine and Medical Device Authority. So the only, as what it said, I think the only way is now to see how best we can improve them, because they are ours. That's where we go every day whenever we are feeling sick. So again to your question, you asked about the number of actual referrals that came from the adults, the health facilities. Actually for us, we are very happy to see that data, because we had a very big argument with the Ministry of Health and the PORA regarding linking clients from the community health workers to the adults. And then by then we identified some of the minor illnesses that community health worker can link adults to the health facilities. And these were like mild rashes, headache, and mild diarrhea. So we had a list of very, very minor illnesses that community health worker were allowed to actually link clients. So don't call it referral, to link clients to the adults. And actually from the data that are projected, for us we are very, very happy to see that data, because we envision that all those who actually arrived at the adults were supposed to be given some kind of medicine or advice, only that. But again, the adults were very, very professional in terms of conducting further screening and providing referrals to the facilities. And that's why you see almost 4,000 referrals coming from the adults to the health facilities. So I think I'll stop that and I'll round up until it continue. Thank you.
Yeah, and I should also commend all people asking questions. Those questions are very important ones. And starting with my young brother from Nyankuru Center, those questions are very important. You know, one of the missing links which has been existing is you don't have access to data, and we don't have access to the information of what is happening in our adults. But adult, it's a data machine. Majority of us, we do not know what is happening. So under this system, what we try to do is try to engage them, to understand what is happening inside the adults, and to know the type of the clients who are attended at those adults. And that helped us to be able to know what type of interventions to be actually provided by the adult. Especially when it comes to the acute low-train diarrhea, the ORS. You know, this is it needs only time for you to attend. You miss that one, you lose some. And this is what we have done also for the new kind of CHWs. That they will be provided with ORS, they will be provided with antimalarials, but the antimalarials will be provided upon allergy tests. One who tests positive will be given first dose and then referred to the nearby facility. Why does that? Actually, we went into literature and learned that malaria kills most in the first 24 to 48 hours if there's no early intervention. And also, we tried to stratify the country into number of stratas. There are places like Lokanoka, there's places like Honosokwan. Within the district, you have to travel up to 3 hours. So you have no any option whatsoever that will save you. So all these were taken into account. But with the new community healthcare workers program, there will be some adjustment to what the Afya-Tek is doing, because the medicines will be dispatched at the facility level. Then these community care workers, upon attending the people, they will be reported back to the facility. And we have assigned them an average of 100 to an average of 70 to 100 households to be visited per month. But in terms of the medicines, they won't be waiting for months to report back. Instead, upon issuing or dispensing medicine, they will have to report on the very day. That's why we provide them with tablets to do so. So we are going to digitize everything. And we are trying to run away from using the paper-based tools to the electronic-based tools. Because we have seen and you have learned from our previous practices, and whenever we use the digital tools, then our data has improved tremendously. So we want to back into that.